I'm very pleased to welcome, and they have asked me to introduce them only by first names, despite the fact they're both actually profs. Dave and John. And Dave and John are from the Division of Optometry and Visual Science, part of the School of Health Science here at City. They're going to talk for about 40 minutes, something like that. They've asked me to let you know that if you do want to ask a question or raise any points during the session, feel free to do so. But there should be some time for questions at the end as well. And as you can see from the slide, the title of the presentation is Development of a Web-Based Interactive Tool for the Assessment of, and this is a bit I don't know much about, clinical decision-making skills. So thanks very much in advance for being here, and over to the two of you.
Thank you very much, Patrick. This is a double act. I'm going to start, then John will take over, and then I'll come back at the end. Apologies, since we're both optometrists, that this is a bit eye-biased, but we've tried to keep it as generic as possible. Anything that isn't clear, because it's eye sort of thing, just ask and we'll give some more explanations. Clinical decision making. This is a key activity for all healthcare professionals, and it's not easy. It's complex, it's higher level, and it involves cognitive processes. And it requires the integration of lots of bits of information. In particular, the clinician has to weigh up the risks and the benefits to the patient in order to come up with a management plan. One of the challenges that all who teach clinicians face is how do we assess clinical decision making reliably and objectively? And one way that we could do this would be if John wanted to assess my clinical decision making skills, heaven forfend, he could take at random 100 of my patient records and look at them and grade my clinical decision making. Problem is that those 100 patients are gone, and my lousy decision making could have caused all sorts of problems down the line. So there is a difficulty here. We mustn't compromise patient safety when we assess clinical decision making skills. One way of doing this, which has shown itself to be valid and reliable, is to use what are called objective structured clinical examinations. The idea is that the students go around stations, and as they do that, they will come across a simulated patient, often an actor, and they will assess one specific little bit of clinical decision making while the teacher watches what's going on. Now, as you can imagine, this is really a logistical nightmare and very expensive. You have an actor, a student, and a member of staff just to assess one small bit of clinical decision making. Because of that, they don't get many chances to practice. That's okay. And we can't organize these on a regular basis. It's just far too demanding in terms of time and cost. Also, it's difficult to give feedback because it requires hundreds of bits of feedback to get around our 112 students. So there are lots of difficulties. And one way around this is to use clinical vignettes, because they deal with a lot of the difficulties associated with OSCEs. They can be written or computerized simulations of fictitious patients. We've used computerized simulations. They're virtual patients, in effect. And we can, using vignettes, we can expose our students not only to common cases, but to the more obscure ones that they're not going to meet very often in practice. So it's a great way of giving a broad range of experience to students. The gold standard way of assessing clinical decision making is to train an actor to go into an optometrist or another clinician unannounced and to record what goes on and then do a report on it afterwards. Now, that too is far too expensive, but vignettes as a technique have been validated against this gold standard method and have shown themselves to be a useful approach. It's a safe environment. Nobody's going to go blind because of a student decision on a clinical vignette. Now, the kind of things that optometrists do in the course of an eye examination are to take a history and symptoms. They assess the patient's vision by getting them to read down charts, and they determine the prescription for spectacles. They determine the health of the patient's eyes, and that's becoming a very important role for optometrists. Carry out further investigative techniques. One of the tests that an optometrist can do is to measure your field of vision, which is how much you can see in the world around you. But we don't do it on everyone because it's time consuming. So we tend to only do it when it's clinically necessary. And then we've got to interpret all the results of these tests and come up with the right management for the patient. Does the patient need to be referred to a GP or to an eye clinic? If they need to be referred, how quickly do they need to be referred? And how soon do we need to see the patient again? 6 months, a year, 2 years? In the course of this examination, various clinical decision-making skills need to be demonstrated by the student or the practitioner. They've got to choose the right tests. They've got to interpret the tests correctly and make the right diagnosis. And they then have to come up with this management plan. Do I give glasses? Do I refer? Who to? How quickly? So the primary aim of our project was to develop a vignette-based online tool for teaching and ultimately for assessment, though we're still working on that, of clinical decision making. And this was a learning development project that was funded by the Learning Development Centre. With the help of Beiju Shah, our wizard computer operator and programmer, we developed our vignette, and we've got other vignettes in the pipeline. It's a virtual record card, and in it we've tried to include all the possible history and symptoms questions that could be asked by a clinician, and every single test that could be carried out in a routine eye examination. Now, not all of them would be done on everyone, but we've tried to include everything. Assessment of vision in various ways, assessment of binocular status, how the two eyes work together, and examination of the front of the eye and the back of the eye to make sure it's healthy. And the student, when they do the vignette, they can ask the patient any clinical history question they like, and they'll get a response. They can choose any test they want to carry out, and they'll get a result. And we've tried to incorporate really good images in here so that the view they'll get on the vignette is very similar to the view they'll get when they look through their clinical instruments in practice. Over to John.
Thanks very much, Dave. So, in essence, the principal purpose of the project was to develop the program that I'm going to demonstrate live, hopefully online in a moment. But we wanted to evaluate the program, and we did that in two ways. Firstly, we recruited a group of final year optometry students, and it was at the end of the year, very close to their final exams. And the nature of training for optometry is that they do a 3-year undergraduate course. In the 3rd year, they see routine patients that book eye examinations with them within the university clinic, and they're very, very closely supervised during that year. Within months of graduating, they're working often in a high street practice, seeing members of the general public, still under supervision, but much looser supervision than we supervise them in the clinic. So we were really capturing these students, literally within a couple of months of them going out into the real world. And we tested the program using 18 volunteer students, and those 18 students completed a single vignette. We then gave the students feedback on their performance, and we'll talk about the nature of that feedback a little bit later. And then the students themselves gave us feedback on their evaluation of the program. So we put together a short online questionnaire that we asked them to complete, and we'll be presenting those results. But we also had an opportunity to test the program on a group of experienced optometrists. Dave and I are research collaborators where we're very interested in how optometrists practice in the real world. And we had an opportunity because we had this group of 100 optometrists that had volunteered for another research study that we could test the program on experienced optometrists and just to see how the students compared with the experienced optometrists. Now, the choice of vignette was very deliberate. One of the things that optometrists do in practice, as well as providing spectacle and contact lens corrections for their patients, is to screen for disease. Now, that's particularly difficult when you have a disease that doesn't have any symptoms, a disease like glaucoma. Now, optometrists are responsible in the UK for detecting about 90% of cases in glaucoma. These are people that don't appear to have a problem, they don't have any symptoms. They go along to see their optometrist, and their optometrist detects the disease. And we gave them a relatively difficult task. We didn't present them a patient with advanced glaucoma that maybe potentially would have been straightforward. We presented a patient that was at risk of glaucoma. They had a particular risk factor. One was their age, because it was a patient in their late 60s was the choice of patient we chose, and they had elevated intraocular pressure, and that's the principal risk factor for glaucoma. But there was quite a difficult diagnostic challenge there, because what they had to do is to differentiate this patient from a normal patient, but they also had to differentiate between the patient that just had raised eye pressure and the patient that had glaucoma. So that was probably the most difficult element of the task that they needed to do, and in which case they needed to integrate and assimilate all of this information together to make that clinical decision. So the challenge now is to show you the vignette tool, which will involve getting out of this program.
This is the 10-step presentation. I'm holding my breath.
Now, in terms of the task that the student had to do, the vignette scenario is reasonably complex in terms of what the student had to do. So we first of all presented them with a pretty detailed set of instructions before they completed the task. On balance, this is probably a little bit overly wordy, but we didn't want the student to be confused in terms of what they had to do. So we really covered just about every base on this, and we spelled it out very carefully. And we even included, I think I'll need to do this from the mouse, no problem with that. We included examples of the different, no, it's fine, of the different types of question. So now we've got to log in again. I thought it would throw us out. This will give an illustration of how the students were. So basically they were sent a link to the program and a password. So their username was usually their email address. And then a password that I'm hoping to type in correctly. Okay, so they then had the instructions with some examples of the kind of questions we use. Now, the first type of question, which I'll show you in example 1, is usually the answer to a question. So this is something that the optometrist would ask the patient, why they'd come to see them, reason for a visit. And then the student then clicked on the question, and then they were given an answer. So this is one style of question. Do you wear spectacles? Sometimes. The other style of interaction with the program was from a pull-down menu. So at the end of the process, they need to make a diagnosis from a list of options. And we gave them a very long list, not in this example. So here we have 3 choices, but as you'll see later, we gave them many more choices. They choose their diagnosis and then submit their diagnosis. As Dave mentioned earlier, we have a number of clinical images for grading. So we'll show them a series of photographs, which is their ocular examination, and then in certain situations they then have to rate or grade a particular image. So the idea is that the students then practiced using the examples, and when they were then confident, they then started the scenario. So this is all delivered online. So essentially they could do this from anywhere. They could do it from home or from within the university. The format of the record card represents the record card that they would be using in the third year clinic. So it's a blank sheet of paper, which is what they'd normally be presented with, and they would normally write in these boxes. So in a sense, it's a bit of a crib sheet in a sense. So it's telling them the kind of things that they could potentially do. But generally, the symptoms and history is left blank for them to start to ask questions. So what we did when they click on this, there was a whole load of questions that they could ask. Now, the important thing to mention is there is a timer at the top. Now, what we didn't want them to do is to click on absolutely everything, because that's not the real world, that's not what we want them to do. So every element of the examination was timed so that it added to the clock how long they'd taken. Now, the aim was that this would discourage them from clicking on every test. So if this got to 2 hours, they'd realise that this eye examination was far too long. So we felt that that was quite important to discourage the serial clicker. So we didn't necessarily want them to ask all of these questions. We wanted them to ask questions that were very relevant. So they could, again, there's an answer for every one of these. So again, reason for visit, routine examination, yes, they were very focal. Questions about general health. So this chap has high blood pressure. He's not diabetic. He's taking medication for his hypertension. And significantly, and this was a very important question, to determine whether there was a family history of glaucoma, because this is another risk factor. So this chap, his aunt and his grandmother have glaucoma, so not an immediate blood relative. So running through the test, and I'm just going to give you a few examples. More or less anything that's shaded in here will give an answer. So obviously what glasses they're wearing, their vision with those glasses we can give them. But what I really wanted to show you is that particularly relevant to this scenario is the measurement of eye pressure. IOP stands for intraocular pressure. So they could click on this. They could take a reading of the eye pressure, and we were simulating this method that most optometrists use, at least 80% of optometrists use in practice, which is a non-contact air puff device that will give them an eye pressure reading. So this was the first reading with the machine, the second reading with the machine, the third reading of the machine, and the idea is they take an average of those readings to get an accurate measure. The gold standard, or the reference standard for eye pressure reading, is this test, which is a little bit more involved. They had to put eye drops into the eye. Something has to touch the surface of the eye. It's not normally performed, but it would be the reference standard that they would use in the hospital if they wanted to get an accurate measure of eye pressure. Again, tests that are relevant to this scenario that I'm going to show you is the field of vision that Dave talked about earlier, higher up, there it is. So what this test does, let me give you this as an example. So this will present the results of the visual field test, and what this represents is that's the central fixation point where the patient is looking. And what this test does is that it flashes small spots of light in different locations within your field of vision. You're looking straight ahead, and it's essentially screening for peripheral vision defects, which is a characteristic of glaucoma. This is essentially a normal plot in this patient. They have normal field of vision. We didn't want it to be completely normal, so we did put a point here that was missed at one setting, so it wasn't completely clear. So they needed to recognize that this was a normal variation that normally happens within this test. And again, we talked about images, but one of the tests that optometrists do is to look into the back of the eye. And when you look into the back of the eye, this is the picture you get, the picture for the right eye, the picture for the left eye. This is the optic nerve coming in at the back of the eye. And this is a really important reference point with respect to glaucoma, because the earliest changes in the disease are manifest in this particular region. So they should pay particular attention to that. And they have an option of zooming in on that particular region for a much more detailed examination. And there's a grading that I'm going to tell you about in a moment, which is the something called the cup to dis ratio. I'll explain this in a moment, but they can choose the evaluation of that from the pull-down list. So having gone through all the tests, ultimately what they have to be able to do, and this is a compulsory element of the test. Everything else is optional in a sense, but this really had to be compulsory, because this is their option of choosing a diagnosis. So they may decide that this patient has cataract, for example. They then decide whether they want to see them again, or whether they want to refer them. If they see them again, they select the interval between that appointment and the next. In terms of management options, they can do further tests in terms of recommending them. But critically, if they refer, and this is the referral button, they have a number of options. First of all, who to refer to the general practitioner, directly to the ophthalmologist, with different degrees of urgency. So that's really part of the management. So let me show you some...
John, could you go back to the timer? Just to see
oh yes, the timer. So you'll see that, even clicking a relatively small number of things on the screen, you can see that the already 15 minutes of their time has been taken up. So let me just show you a few results. So what we are really interested in our sort of comparison and our comparative exercise is, first of all, whether they chose the right test from the number of options available, how accurately they graded the things that needed to be graded, how accurate their diagnosis was, and ultimately how appropriate their management was. Now, obviously, in this exercise, there is a certain benchmark, certain reference standard, and that is the advice given by the College of Optometrists, which essentially says these are the tests you should or could do in particular scenarios. Relevant to this are patients that are at risk of glaucoma. So we would define our patient as being a patient that's at risk in two respects, really. One is by virtue of their age and by virtue of their family history. So this guidance would be wholly appropriate. The college are telling them they should look at the optic nerve in detail. That's important. They should measure the intraocular pressure, and they could. These are all kind of really musts or should do's. These are could do's or may do's to measure the field of vision. So students on your left, as you're looking at the screen, are experienced optometrists on the right. So our students were pretty good. They all did the detailed assessment with their ophthalmoscope, looking at the optic nerve. Had no statistical difference between these two groupings here. 100% of them did the right thing in measuring the intraocular pressure. A reasonably high proportion used the reference standard that they would be using in the hospital, and again, the vast majority of them did a field test. So very good, really, at choosing appropriate tests. Now, the grading accuracy, one that's probably most relevant to this, is a measure of what's called the cup to disc ratio. So we'll look at this in more detail in a sec, but the cup is the central, usually pale area, and what they need to do is to estimate this central circle as a fraction of the overall size. So it's essentially two concentric circles. So if this cup was half the area of the bigger circle, that would be a CD ratio of 0.5, so that's essentially it's 50%. If it was roughly a third, that would be 0.35 in our grading system. So we wanted to see how good the students were at grading this really important clinical measure. And it's important in glaucoma because the higher the CD ratio, the greater the likelihood of them having a disease. So complicated graphs, it's all the data presented. These are the students and these are the experienced optometrists. These values sort of up here and down here are considered to be, the computer program recognizes those as outliers, those are falling way outside of the kind of peer group. The box more or less represents the kind of middle 50%. So the broader the box, the greater the variability. So they were much more or much less variable in the grading of the right eye, much more variable in the grading of the left eye, but there's actually very little difference between the experienced optometrists and the students, and no statistical difference either between the means or the medians. So that's really saying that our final year students are at least as good as the experienced optometrists, often with many years of experience. There's so far no difference. But what about their diagnostic accuracy? This is where the differences start to arise. So here are our students. Only about 28% of them got the correct diagnosis, ocular hypertension. 71% of the experienced optometrists got the diagnosis right. In terms of the differential diagnoses, glaucoma was probably the most likely one they would confuse it with. Indeed, the students did. Half of them felt it was a case of glaucoma. Only 15% of the experienced optometrists. And then the percentage of the normals was roughly equivalent, but you can see high levels of statistical significance between the groups in terms of their diagnostic ability. When it comes to management, well, as luck would have it, the management of ocular hypertension and the management of glaucoma is the same. It generally instigates a referral. And so even if the optometrists were, or the student optometrists were getting the diagnosis wrong, they would often get the management right in deciding to refer. And again, very little difference, in fact, no statistical difference between any of the groups, with just one exception around urgency of referral. So handing back to Dave now.
Thanks, John. Well, a key element of any teaching and learning is getting feedback from your students, and we wanted to get feedback on the entire process. So every student was sent a detailed breakdown of the scenario with a PDF file. We gave them information on whether they'd done appropriate investigations, the grading of the images, diagnosis and optimal management, and we suggested some further reading. And at that point, the students were encouraged to have another go at the scenario, having had our feedback on how they'd got on. Now, this feedback we gave them was generic. It wasn't specific to the individual, and that's something that we hope to build into the next version of our vignettes. Each student had another online activity that we encouraged them to do, which was to evaluate the questionnaire, on a questionnaire, and we were interested in the following aspects of the vignettes. How easy it was to access and use, the content and the relevance of the material presented, how good our feedback was, and of particular interest to us was, could we use these vignettes not just in a student population, but could we take them outside of the university and use them on students doing their pre-registration year, or registered optometrists who have been out in practice for a while, because we learned from the results of our experienced optometrists that not all of them were getting the right results on our ocular hypertensive patient. And then we wanted an overall rating of the vignettes as a whole. And the student evaluation consisted of a series of statements that we gave. We asked the students whether they strongly agreed, neither agreed or disagreed or strongly disagreed with each of those statements. And first of all, access, usability and quality. We wanted to ask if it was easy to access. Now that seems like a daft question, but often we've learned from surveys that we've done that one of the great challenges is for students to be able to get onto the website and use the thing. And 100% could do that. Were the instructions easy to understand and helpful? 2/3 strongly agreed. There was a view that we were perhaps going overboard in our instructions, and one disagreed. I'll come back to her comment. Easy and intuitive, 2/3 felt it was easy to work through. They liked the quality of the images. Controversial was the timer. They didn't like the timer. Because our students are used to spending 2 hours on an examination, and we were encouraging them to work as they would do in practice, which they'll all be faced with really soon, where they're going to have to do an examination in 25 minutes. And they didn't like this very much.
It wasn't a strong dislike, was it?
No.
You got a third of them approximately.
Yes.
But they've taken their sitting on the fence.
Yeah.
Gone into the
Some of the literals were interesting. I've got a couple coming up. It was felt that the level was appropriate. It was a good patient to choose. It was realistic. And they felt that it had enhanced their clinical decision-making skills. The quality of the feedback, they liked the feedback. It was appropriate, easy to understand, and they felt that it developed their clinical decision-making skills. 18 students did the vignette, and we felt quite pleased that 17 of them went to the trouble of doing the feedback. They were really good. Likely impact on future practice. We want to take this out of optometry, and we want to take it out of the university if we can. So our students don't do placements, as John has mentioned. They do what's called a pre-registration period of roughly a year after they leave the university. All felt that vignettes would be a useful learning tool while they were out there, and we invited them to try and look a bit further ahead. They felt the vignettes would be valuable for ongoing professional development after qualification. Overall rating was encouraging. We were really pleased. They thought this was an excellent process. Got a few of the free text comments. First of all, on access, usability, and quality of presentation. They liked the layout. A typical comment on the timer was, I didn't realize what it was at first, otherwise I would have skipped a couple of tests rather than reveal the results of all the tests. But, well, that was the point of the timer. So the message got across, but we maybe didn't make it clear enough at the start. Content and relevance. Everything was relevant and made you think how you would assess the patient in practice, how you'd manage them, without the risk of missing something in a real patient in real life. One of the key advantages of vignettes, and I was pleased a student picked that up. We got a lot of really constructive comments here about things that we could change or add to the vignettes, and this was typical of those. You could include a referral letter, because we are often referring our patients to GPs or to eye hospitals, and the students could select what they felt was relevant in the referral letter, and that's something I think we could certainly do in future versions. Form and quality of feedback, very detailed. They learned a lot from it. Typical comment, very informative. However, it didn't feel personalized to my answers, and it wasn't. At this stage, all we could do was give generic feedback. However, we think that our programmer will be able to tinker with the program so that we can give some form of individual feedback to our students in future. Likely impact on future practice, ideal for the pre-registration period, as they can independently revise content outside of the university environment. And for post-qualification, I liked this one because it drew attention to the fact that they could improve clinical decision-making skills in scenarios they may not see frequently, because there are important sight or life-threatening conditions that an optometrist could encounter, but they're very unlikely to encounter them often. So here we can come up with that 1 in a million case, and they can learn how to deal with it. Summary. We think our tool is an effective method of teaching clinical decision-making. The vignettes were well received by the students. The comparison with experienced optometrists was fascinating. It showed they chose the right test, they could grade correctly, but they weren't so good with their diagnostic skills and with their choice of management option. Future work is to develop the system for personalized feedback, and part of our task was to gear this to assessment, and we haven't developed the scoring system yet, but that again is on the agenda. We couldn't have done any of this without Beju, a marvel. We were so lucky to have a PhD student who happened to have this experienced bunch of optometrists that we were surveying for other reasons. The students were wonderful, and so was the Learning Development Centre for funding it. We came up with a couple of discussion questions. What are the merits and limitations of vignettes compared to other methods of assessing clinical decision making? And could you take this interactive tool out of optometry into other healthcare professions? Or anything else you want to discuss?
Okay, well, first of all, should we just say thank you both. How would you like to take things forward? Shall I invite people to offer some contributions to those discussion questions first of all,
yes.
and then we'll go into more general questions afterwards. So would anyone like to offer some contributions with respect to the two discussion questions first of all?
Well, I've spoken to you before, and I think I'm a speech and language therapist, and I think it does offer a huge mechanism for trying to get practice for our students as well, if we can adapt it in that way. And I did want to ask, A, how long it took, Beju, is it, to do it? And then, is it, and then can you upgrade it all the time, and can you, what I didn't quite gather is, in the vignettes, are there eventually quite a large number, so that you put in something so that you might get any sort of a
no, that's true. I think the way that it works, let's take the history and symptoms questions. All of those answers are effectively in an Excel spreadsheet, and it pulls in those answers into the program. So it's obviously very easy to put any, because the questions are the same, but the answers, of course, will differ depending on the patient.
So I suppose in ours you might get sort of really peculiar case histories, I suppose.
Oh, yes.
So
I mean, so the history taking probably in your case would be much more complex in a sense. I mean, ours tends to be a little bit more prescribed in the sense that there's usually a set number of questions. Similarly, with the kind of back end of the program, we could go in there to change the images. I mean, as long as they're appropriate in size and resolution, there are certain limitations there, but we could effectively build an infinite number of scenarios within this format now.
The real challenge is doing the first one.
Yes.
I was going to say, how long did that take?
It's a nightmare.
Well, it's probably, to do the programming, I guess, is taking him the best part of the year, really.
Yeah.
Because there was an awful lot of beta testing, as you might imagine, along the way before we used it on the students.
I mean, we had hoped to have 4 vignettes by now, but the first one's the difficult one, because as John says, we can now put different images in, we can change the responses, and I think it'll be far easier to build up a bank of vignettes now.
So you effectively have one, and then you can select different options to build up another one.
So we could alter the age of the patient, alter the presentation. You know, we could the emphasis here was on disease, but the emphasis equally could be on, making an appropriate choice of spectacle correction, for example.
Yes.
So,
I mean, our students are really good at coming up with a final prescription, but you often don't prescribe that. You modify it based on what the patient's wearing already, or how well you think they'll adapt to change. And that's where they find challenges. So it's not just disease. We can address every aspect of optometric practice.
That's starting to answer or is answering the question I was going to raise. Because you mentioned during the talk that you were going to you intend to take the project forward further phases. Any other ways you want to drive it forward in the future? Because as the evaluation shows, it's been very well received. So,
Well, I think the important thing, as Dave mentioned, I think, was the individualised feedback. And you can normally divide the examination into a number of components. One is the history and symptom section. Did they ask the key question, so they could be graded against that? Similarly, did they choose the appropriate tests and interpret them correctly? So that's another kind of bank of feedback that you can give them. And then finally, it was on the diagnosis and management. So we think that we can develop the feedback in an individualized way along those 3 key areas: history and symptoms, investigation and interpretation, and then finally in diagnosis and management. So they'd get the feedback in that form.
Can I just add to the feedback questions? At the moment, do they get told whether they, you know, the questions, case history questions, and you could ask this.
Yes.
Mm.
Do they get feedback? Actually, you only needed to ask these 3 for this, or 4, or
Well, we said what the key ones
The key
were.
In,
ones.
in
Yeah.
our generic feedback
Yes.
we did.
Yeah.
fine, yeah.
Yeah. Because we divided our feedback into those areas, history and symptoms, you know, yeah, and similarly, you know.
But it's quite interesting that our students tended to ask lots and lots
Yes.
of those questions, whereas the more experienced practitioners
Yeah.
were more selective. But that's
That was
understandable.
I think because there were 24 potential questions they could ask, and I think the average was probably 23. So they tended
It's the point
to
of practice.
ask just about everything.
What would have been the average for the qualifying?
Quite a bit less than that, more than half.
Yeah.
So I don't think we've got that precise value, but my interpretation
14
of that.
maybe, 14,
Yeah.
15 would be my feeling.
Yeah, yeah.
So
That's
they're,
appropriate.
yeah.
Yes, it is. Because a lot of the questions really should have been ones that, you know, it's a trigger from a previous question. So you ask that question, if you get positive, you then ask the subsequent ones.
I
Sorry.
have few questions. Kamal Pal from School of Informatics. Which programming language your student used to implement the system?
Ah, yes.
I'm not sure I know the
We
answer to
have-
that question.
Oh dear.
I think
we're out of our comfort zone.
I think you're talking to a couple of Luddites here when it comes to computer programming language.
I have second question.
Yeah.
When you are giving the feedback, did you give the feedback in a paper-based or online
Yes.
within the system?
No, the aim would be ultimately to give it back, you know, in real time. When they finish the scenario, then the feedback would appear. We did it for this exercise as a PDF file, which we then emailed to the students
Right.
alongside the invitation to ask them to fill in the online questionnaire.
Yeah, this,
the way
this,
we
this
did
was
it.
slightly different exercises. To complete this, we really wanted them to give us the feedback. So this was an opportunity for us to send them an
Yes.
individualized email to prompt them
Yes.
to do their feedback on the vignettes. But you're quite right. In the next version, we would want to embed that into the system so that they
Yes.
got it automatically.
Yeah.
My
Third question.
sorry,
That's okay, no, go ahead.
Give the opportunity to others.
Yeah.
Now it's okay.
No, go ahead, please.
No, please do.
There's time, there's time.
Other question, who act as the domain expert? Is Dave and John or other people also?
We were the domain experts in terms of this particular scenario.
How many hours you spend with your student to explain or give the...
Well, we were very lucky because it just so happens that the programmer, his wife is an optometrist.
Oh, wow.
So
And she
in
did her
terms of-
PhD here.
no, which was very, very useful. I mean, you know, obviously a lot of the clinical questions, you know, she would have fielded, but there were a lot of other issues, you know, that we wanted specific to this scenario. So we were essentially providing that level of feedback, but the very fine level, you know, that he would have just asked his wife.
Yeah, he asked.
We're very lucky.
Yes, although we didn't get as many questions as expected because Raki was able to answer most of them.
Yeah.
The next question is that in which format they represent, or your programmer or group of programmers represent the domain knowledge? Is it rule-based or experience-based?
Okay, do you want to take that question and then I want to answer?
We should have asked Beju to come along.
So you might get a chance to ask.
But
we-
other people that want to ask some questions as well.
We should know the answers to these questions, so thank
Yes.
no,
Thank
no.
you. But we can find out.
Quite a quick one. As Moodle developer, I wondered if you looked at Moodle at all.
Yeah, we did, and we tried to investigate that, and it wasn't as straightforward as you might think. There were some initial issues with getting it integrated with Moodle that would have been not unsurmountable, but would have put such a delay into the program to get that level of integration. Obviously, with Moodle, because it's an external website, you know, we can take them out of Moodle and we can integrate the feedback in through Moodle ultimately. But I think in terms of getting the program to run within Moodle as a platform issue, I think that would have been more difficult, because he did talk to the director of computing at the outset to try to get that level of integration, because obviously that's what we wanted, ideally.
Okay. Now I know there's at least
Go ahead.
questions. Having said that, we have got quite a bit more time.
Ah,
so
yeah.
At this stage, there's
No panic.
I'll
No
be
panic.
quick, and if
So-
you believe that I've got learning and teaching question rather than a technical. My name's Sarah, I'm from Digital University College, so I'm really excited to take this project back to our school of health, because I think they absolutely think it's fantastic. What I'm really curious about is, does the student get the ability to go back and then see what they've done? So when they get the PDF that says, these were the key questions that you should have done, can they then go back and say, oh, I can't remember, did I ask?
Yeah.
Did I
No,
do
They raised that.
Yeah, that's something we would have liked to have done. The way that it was set up for this kind of first phase was that we reset the program, so effectively erased their comments to allow them to start it again. But what we hope to do with the feedback in future is to say, this was your answer, and this was the, what you should have said, or should have asked, or should have graded.
And just the other piece of that, I think it'd be interesting to know whether the students felt this would have been useful for them or not, was whether they then could get together as a group to discuss their decision making as to why did they choose.
Oh, that's a good idea.
That's a very good,
That's a great
as a
idea.
peer review thing.
Yeah.
I think that would be excellent, because I think we felt, Dave and I have discussed this, but we think in a tutorial type format, kind of working through the scenario with a group in real time like this on the screen would have been very useful as an
What you
exercise.
can't do with a real patient. So it's
Exactly.
really nice.
Exactly.
Or actually, I wonder whether, and maybe this is pushing things a bit too
Yeah.
far, is that having the opportunity as a student then to, or sorry, they're not students anymore, are they? They're in practice.
Yes.
But have the opportunity then to meet with the experienced people to understand from
Yes.
them
Yes.
Yeah, why they did.
Yes,
it.
absolutely.
misdiagnosis,
Yeah,
so
yeah.
that you're creating
Yeah,
from
yeah.
this whole piece
No,
a
you're
bigger
quite-
community of practice.
No, you're quite
It's
right.
a great idea.
Yeah,
It's a great
so
idea.
It's exciting. I'm very excited.
What is your discipline?
Well, my original discipline is business.
Oh, right.
But I'm in the learning and teaching team, but I specialise in assessment now.
Ah, okay.
Right. Because I think although it's a single decision in this particular case, whether it's ocular hypertension or glaucoma, but as Dave said at the outset, that's very high level processing, because you're integrating so much information to make that decision. And obviously, the experienced optometrists have acquired that through experience, and it's really trying to kind of drill down to that level of processing is the difficult one. And the challenge is to take them from where they are now to where the experienced optometrists are.
Sorry, I'm hogging it on.
No, there's plenty of time.
But the thing that I find very fascinating about your research results is the whole debate around how much you can actually teach and how much you learn on the job.
Yes.
That's what you're starting
Yeah.
to demonstrate.
Yeah.
You can only teach so much. But then when you see the difference between the guys that have got all the technical know-how, that
Yes.
but actually when you're in it and you're doing it, and how, and almost I suppose there's bigger questions and more research there as to how do you then help accelerate.
Yes.
Yeah.
Can you even accelerate that?
Well, what we would hope is that this might serve to accelerate the process, if only in some small way. But
Yeah.
there's potential that it could, I
This
think.
has got huge potential.
Because the thing that surprised us, I think if you'd asked us at the outset before that comparison, we would have said there should have been differences, we felt, between the students and the experienced optometrists in all aspects, selecting appropriate tests, grading, but it was really only at the end point, the management and the diagnosis, where they differed. In every other respect, they were doing as well as the experienced practitioners.
And one of those discs was very difficult to grade. They were chosen. One of them was
Yes.
easy-ish, but one of them
Yeah.
was I would say
Yeah.
it was a challenge for anyone. And they did as well as the experienced practitioners, which was good for the students.
Yeah.
I think this is fantastic. I mean, I'm from diagnostic radiography,
Mhm.
and the way things are changing with the extended role is that we are actually now encouraged to, for the students to do more evaluation and
Yeah.
actually make diagnosis, because you have reporting radiographers who do it postgraduate.
Oh,
anyway,
yes.
so it can lend
Yes,
itself to
yes,
that,
yes.
and the whole process that builds up to that.
Yeah, yeah.
My only question is a little bit controversial, and it's probably not to sort of put it down in any way,
Yeah.
but I'm just wondering, because students being students,
Mm.
they had an
Oh yes.
You didn't expect
Yeah.
as much of them, and perhaps they thought, oh, it'll be glaucoma. It won't be anything extraordinary. And I just want, because you haven't had the opportunity to prove that yet, because
well,
you need to
it's
build more.
Yeah, it's a good point. We're glaucoma
think,
men, so they would. Well, you do everything.
but I think that's right. I mean, I think in a sense we tried to mitigate against that in the sense that when it came to the diagnostic bit at the end, there was at least 12 possible diagnoses. And so, they were probably thinking there's something wrong with this patient.
Yeah.
It might be routine, but, and they, would have been wise to that. But they could have potentially chosen a number of different diagnoses there. And it wasn't obviously glaucoma. I suppose the one thing that, if we hadn't given him a family history, maybe it might have.
I mean,
So
it's not
that,
my lack of knowledge of optometry.
yeah.
No, but I mean, you raise a very valid point, and I must confess again that we hope to have 4 vignettes.
Yeah,
Yes.
but more. You'll
Yeah.
know.
Yes.
So we would have had a range, and we were going to
Yes.
put a normal in there as well.
Oh, yes.
But yes, it's a very valid point.
But also their expectations will change once you've got many more. And you think,
Oh,
actually,
yes.
no, they're going to test us at all levels.
At all
They're
Yeah.
not going to just have
No, that's right.
low expectations of our
Yeah, yeah.
ability because we're students.
Yeah.
Will you be able to make the improvements that you want to make, or
Yes.
is money run out?
No,
No,
well,
no.
we've got two more. Well, rest of June and July.
And he's currently working on the scoring. So he's developed the bit which allows us to build the new scenarios by going into the back of the program and feeding it with new information.
So in fact, that once that's done, it'll grow of its own volition.
Yeah,
without
yeah.
needing
We hope so.
huge amounts of funding.
Yeah.
Yeah, I think there will be maintenance money that will
That's
be needed.
the issue, because we couldn't do the Moodle integration, so that it would have been a program that would have been difficult for the university to support from a technical perspective, because we did explore that. So there's an element around sort of external hosting, sort of it's on another additional server.
Actually doing it in Moodle with the quiz, which back-end developers are not that brilliant at
Yeah.
and stuff, but just whether the quiz tool could have actually achieved
Yeah.
something or not.
I think it would be probably easy to do in parallel, on the same topic, to have a Moodle quiz specific to the scenario. So they'd run the scenario, but within the scenario there are not sort of specific questions. So in the way that we would assess them as undergraduates, so either in multiple choice type format or short answer format, I think it would be possible to do that. Taking images from the scenario and putting into the Moodle quiz would be straightforward, I think.
Okay, we've got time probably just for a couple more questions. So one here. Anyone else want to? And then one from yourself afterwards. And I think that will probably bring us towards the end of time. So maybe take the 2 questions together.
It's quite a general question. I was just thinking, have you had sort of interest from other professions? That have you presented this anywhere else where they've actually? Was this the first
No.
time you
It's the
presented?
first time.
The poverty of our presentation
Yeah.
reflected the fact that this is the first time that we've.
No.
we've
I assume that you have.
No.
I'm thinking other health professionals have they?
No. This is a
No,
virgin
you
presentation. So
But I agree, I think it would be very good, because
Yeah.
I think even within our discipline, because we've got so much more data that's much more clinically orientated, that for a different audience we could have said.
yeah. No, exactly. I mean, we would love to take it out
Yeah.
of optometry because we think it's got
Yes.
value beyond our
Well,
profession.
you told them you should have come to help us.
Yeah, I know. We had very little to show you then, unfortunately.
Yeah, that's true. No, that is true.
I have a very non-technical question.
Ah.
Non-technical. Have you published any paper out of this?
We plan to. We haven't yet. Well, I mean, the evaluation and the analysis is very recent, because there was so much time taken up with the programming. This kind of student evaluation came right at the end of the project. So that's literally within the last couple of months. We got a fantastic data set for publication, we feel.
I mean, one thing I would maybe put to you, because we don't know. I mean, is the design and the use of this and the evaluation of it on its own, is that something that an education type journal might be interested in?
It could go to the main hardcore, the computer science journal.
Really?
Yes,
Yeah.
I do that.
Yeah.
and you can send it for educational journals.
I mean,
teaching and learning.
I think you've got a couple of potential
Broad,
publications
Because
from it,
I
haven't you?
feel
Yeah.
more
Focusing on different development issues.
Yeah.
Yeah.
That's one thing. I
Yeah.
just recently reviewed a paper looking at the use of technology
Yes.
games for cerebral palsy sufferers.
Oh,
Mhm.
yeah.
And the problem with the paper, unfortunately, has been rejected. But the problem is it was too long.
Ah,
What they should have done was done a review of how
yeah,
they
yeah,
developed
yeah,
their tablet,
yeah,
For that particular
yeah,
thing.
yeah,
and
yeah, yeah.
then how they've analysed how the games have been used,
Yeah, sure.
and then published the results,
Yeah,
and
yeah,
then
yeah.
tried to mingle it all
Oh,
together.
yeah.
But I think you've got you've probably got a development side,
Yes.
you've got a results side, but then
Yeah.
you've also got a follow-up side
Yeah.
as well.
Yeah, yeah,
And
yeah,
it's
yeah.
on-
undergrad
Following
and
out.
postgrad.
It is, of
in
course
all
it
is.
professions.
Yeah, yeah,
It,
yeah.
yeah, it would just, it would be vast.
I
Yeah,
can
yeah.
tell you from my experience, John, you can publish this without knowing the implementation. Your student has used rule-based system.
Yeah, yeah, yeah.
If it happens, then this.
Yeah, yeah, yeah.
You can give a architecture and present what you found, and it could go to the hardcore computer science journal.
Oh,
Impact factor 3 onwards or less than 3,
gosh.
and it will publish without any problem.
Yeah.
I
Oh,
agree,
thank you
and
for
even
that.
though it's optometry bias,
Yes.
and I don't have no knowledge of optometry,
Yeah, yeah.
I understood.
Yeah.
I got to grips with what you're actually doing.
Okay, thank
Well, it
you.
might keep us on a job, yeah, John.
Yes, on that point, the education.
Yeah.
On,
Yeah,
on,
yeah.
that, on that point, we'll have to bring things to a close. I think we'll all agree we've been very lucky to be amongst the first to hear about this
Yeah.
Yeah.
brilliant project from John and Dave. So thank you both very
Okay.
much again for talking today.
Thank you.